In the name of Allah, the most gracious, most merciful. At the outset, I must congratulate General Farhan, General Afshin, and their team for organizing such a successful event, and I'm thankful to them for giving me the opportunity to talk about the missing links between vitamin D and cardiovascular system. You can well imagine the importance of vitamin D, that bearing this vitamin, research in rest of the vitamin has almost leveled off. And most of the research is trying to answer, do lowering of vitamin D levels mean high risk for cardiovascular disease, or is vitamin D a new therapeutic option in coronary artery disease? My sequence of presentation is going to be vitamin is a substance which can't be produced by the body. Vitamin D is called vitamin because in the beginning it was never appreciated that there is a factory in epidermis which can churn it out. Label D was assigned to it as it was the fourth vitamin to be discovered. Actually, it is a steroid, and that too a corticosteroid, as it has got a broken ring. Optimum levels are considered to be 50 to 70 nanograms, but as a heart disease therapy, levels up to 100 nanograms per milliliter may be required. Worldwide, more than 1 billion people suffer from deficiency of this vitamin, and in Pakistan, hardly 20% of the population have got sufficient levels of vitamin D. What's the role of vitamin D in cardiovascular system? 7-dehydrocholesterol in the lower strata of epidermis is converted into pre-cholecalciferol under the UVB light of 280 to 350 nanometers, which at 37 degrees centigrade of body temperature becomes cholecalciferol. This, along with the vitamin D absorbed through gut, circulates in the blood bound to the protein. Later it passes through liver and kidneys for hydroxylation. Ultimate effects are mainly on the musculoskeletal system. Rest of the effects are arterial hypertension, coronary artery disease, heart failure, and ventricular electricity delay. After second hydroxylation in the mitochondria of the proximal convoluted tubules of the kidneys, vitamin D enters the cytoplasm of target cells and gets bound to vitamin D receptor. This complex then enters the nucleus to get attached to the retinoic X receptor, and both the receptors then attach to vitamin D elements and form here the gene expression takes place. More than 1,000 genes are involved in the expression, and that is approximately 3% of the genome. Cardiomyocytes, endothelium, renin, angiotensin, aldosterone system are the main targets, with inflammatory and immune cells also taking part. This is how vitamin D and cardiovascular system are interrelated. So, vitamin D through different mechanisms affect the cardiovascular and related diseases. Cardiovascular system is either directly affected or indirectly through the risk factors. Hyperparathyroidism, RAS activity, cellular proliferation, endothelial growth, and inflammation play the major part. Here I must point out that parathormone plays the bad part by turning the things ugly for the cardiovascular system. So we can say that the actuator of the problem is parathormone. Let us look at some of the trials. In LURIC ongoing study, it was observed that among 1,801 patients sent for coronary angiography, 92% had suboptimal levels of vitamin D with increased mortality rates, and in Framingham offspring study, individuals with less than 15 nanogram per ml had hazard ratio of 1.62 for cardiovascular diseases. And this problem is more pronounced if the levels of vitamin D are less than 10 nanograms per ml. Significant association has also been found between vitamin D levels and premature atrial or ventricular contraction, as well as with acute intervals. Hypocalcemia induces electrical changes in cardiomyocytes and may be the cause of increased risk of post-operative atrial fibrillation. Talking about the supplements, reduction in blood pressure, lowering of cholesterol levels, and improvement in the diabetic control has been seen in some of the studies carried out to see the effects of vitamin D supplements. Calcitriol, which is 1,25-dihydroxy vitamin D, may be less even when the cholecalciferol are normal, as calcitriol affects the inflammatory and metabolic markers, so its role may be more important in prediction of cardiovascular disease risk. And it has been observed that vitamin D supplements can reduce the burden of premature ventricular contractions and help in avoiding antiarrhythmic drugs or catheter ablations. Supplements are also been helpful in reducing post-operative atrial fibrillations. But unfortunately, despite a likely association with vitamin D deficiency and a greater incidence of cardiovascular disease and its related mortality, the intake of vitamin D supplements has not shown consistent results in terms of reducing the risk of cardiovascular disease in recent large random controlled trials. Whether it was VIDA study or vital trial supplements, both failed to show significant benefits. So where are the missing links? Is it the dosage which needs to be optimized? Or future trials should be on vitamin D deficient patients? Or ergo and calcitriol should also be used besides cholecalciferol? Or duration of the trial should be prolonged and number of patients should be increased? Or besides total 25-hydroxy vitamin D, its free level should also be catered for. So can we say that the heterogeneity in strategies, inadequate dosing, less duration of the treatment, and failure to achieve optimal levels of vitamin D could have been determined negative outcomes? Not to forget that genetics and environmental factors also affect the outcome. So recommendations are that the cardioprotective optimal dosage needs to be determined. Effectiveness of cholo, ergo and calcitriol need to be compared. Trials need to be at least more than a year, and total and free 25-hydroxy vitamin D to be compared also. In the past, Shakespeare's question was to be or not to be, but the present one is to be or not to be. So my take-home message is, get your vitamin D levels checked, and if low, take high-dose weekly supplements for a few weeks followed by low-dose supplements. Recheck the status after a few months and maintain 25-hydroxy vitamin D levels close to 70 nanograms per ml or up to 100 nanograms per ml if aim is for cardiovascular benefit. In white people, exposure for few minutes twice a week is sufficient, but in brown and black, more exposure to face, arms and legs is required. Remember, windows glass completely blocks ultraviolet D radiation. And the secret of tanning beds is that UV is only 4 to 10% in their UV emissions. The kids should be encouraged to have outdoor activities rather than playing video games, and their diet must include fatty fish, liver, and dairy products. And we must keep in mind that 90% of our vitamin D comes from the sunlight. I would conclude by saying that vitamin D deficiency appears to be involved in the pathogenesis of cardiovascular diseases at several stages. Large-scale, well-controlled, randomized controlled trials are needed to prove that vitamin D supplementation improves the cardiovascular outcome. I thank you very much for patient listening, and before I fly away, are there any queries or questions or comments? Thank you very much.